Good morning, everyone. Today's lecture topic, conservative dentistry lecture topic, is tooth preparation for Alzheimer restoration. And I'm Dr. Priyanka. And as you can see, this image shows us an all ceramic beautiful restoration, which gives us a proper and perfect color gradient and translucent. Okay, coming to the learning outcomes, we will be discussing five things. That is, we will be discussing the advantages, disadvantages of all ceramic crowns, also the indication and contraindications. We'll be discussing steps of crown preparation in all ceramic interior crown. We will be discussing all ceramic crown preparation errors. We will be discussing principles applying for all ceramic crowns, that is the tooth preparation principles, and we will also be talking about selection of patients for all ceramic crown. What are the factors affecting that? Coming to the introduction, all ceramic inlay, onlay, veneer, and crowns are some of the most aesthetically pleasing prosthodontic restorations because there is no metal to block out the light transmission. They can resemble very naturally the tooth structure, which are very good in terms of color translucency rather than the other restorative options. So you can see here is an example of like a full mouth, full rehab, all ceramic restoration, right? With a very good variation of color, translucency. There is no metal, so there is very good light transmission as well. Alright, coming to the advantages, of course it has superior aesthetics and excellent translucency. Similar to the natural tooth structure, generally it has a very good tissue response. It has a lack of reinforcement by the metal substrate, which enables slightly more conservative reduction of the facial surface than is possible with the metal ceramic restorations. So you can see that 1.5 mm is supposed to be reduced, and there is a surround preparation of 1 mm. The appearance is very close to the natural teeth. The appearance of the completed restoration can be influenced or modified by selecting different colors of luting agent as well. So we can do some luting agent shade selection as well, guys. Okay. So disadvantages are as follows. The disadvantages of complete ceramic crown include reduced strength of the restoration because of the absence of a reinforcing metal substrate, right? So the translucency, yes, is there, but metal gives us a proper strength to the porcelain layer, which this lacks. Because of the need of the shoulder type of margin circumferentially, significant tooth reduction is necessary on the proximal and lingual aspects. So, proper 1 mm tooth reduction is required everywhere. That's a little bit, a lot more than metal ceramic, and it is towards the non-conventional tooth reduction approach, right? So we have to do a little bit more than a proper conventional PFM crown preparation. Okay, porcelain has brittleness, which is combined with the lack of reinforcing substrate substructure, which requires incorporating of circumferential support with the shoulder margin. Thus, by comparison to the proximal lingual reduction, are less conservative than those of metal ceramic crown. So I just described that. So porcelain has an unforgiving nature. If an inadequate tooth preparation goes uncorrected, it can result into fracture, shown in the picture below. That is a fracture line which is kind of masked with the composite or composite restoration, basically, right? So can you see like a fracture line here, guys? Just to reinforce and not to, it's like a modification that we have done. Of course, in the future, you will have to replace the crown on the lateral incisor. Coming to proper preparation design, it is critical to ensure mechanical success. A 90-degree cable surface angle is needed to prevent fracture, unfavorable distribution of stresses, and to minimize the risk of fracture, right? 90-degree is favorable on the photo here, which is a 90-degree shoulder. If you have a sloped shoulder, it is more chances of fracturing. All right, the preparation should provide support for the porcelain along its entire incisal edge unless the ceramic system includes high strength core. All ceramic restoration are not effective as retainers for fixed dental prosthesis. The brittle nature of porcelain necessitates that connectors of large cross-sectional dimension is incorporated in the fixed dental prosthesis, right? So we will give a connector which is incorporated in the design, in the structure. This typically leads to impingement of the interdental papilla by the connector, which increase potential for periodontal failures, right? So it gives you more reinforcement and it can lead to periodontal failures. Wear has been observed on the functional surface of the natural teeth that opposes the porcelain restoration. So if you have, obviously it's a very common thing that I will not be having all ceramic restorations all over my mouth. So in the opposite, if you have natural teeth structure, it can result to fracture because of the strength. Okay, coming to the indications. Indicated in areas with high aesthetic requirements where a more conservative restoration would be inadequate, right? As you can see here, right? If you really want to match the aesthetic requirement, you can see 1.1 and 2.1, and you can see the photo B. It's the exact same patient, and you can see a comparison with a normal PFM crown and then a all ceramic crown, right? Okay. So usually such a tooth has a proximal and facial caries that has no longer be effectively restored with a composite resin. So usually it cannot be restored. There is no other treatment option. We should go for the all ceramic restoration. The tooth should be relatively intact with sufficient coronal structure to support the restoration, right? So you should have a proper surface. So you have to do proper preparation where it is important not to exceed a maximum porcelain thickness of 2 mm. Otherwise, fracture of the brittle material will occur, right? Okay. Because of the relative weakness of the restoration, the occlusal load should be favorably distributed, right? So we need to see that the clearance is proper, otherwise it will result into fracturing of the restoration, and the occlusal load will be stressed at this portion. In general, this means that the centric contact must be in an area where the porcelain is supported by tooth structure, right? So the centric contact must be in the area where the porcelain is supported by the tooth structure. So always you should place your margins, everything on the tooth structure and not on the restoration. So coming to the contraindications, the ceramic crown is contraindicated when a more conservative restoration can be used. So on the same place, if PFM can be used, PFM should be given. So rarely it is recommended for molar teeth. Because of the increased occlusal load and reduced aesthetic demand, metal ceramic restoration are the treatment of choice. They are much stronger, it can bear more loads, but what I like to tell you here is there are a lot of different ceramics which are actually indicated for posterior teeth, yeah? So it can be used, especially the monolith, right? crowns can be used. Uh, if occlusal loading is unfavorable, right, or it is not possible to provide adequate support or an even shoulder width of at least 1 mm circumferentially, then a metal ceramic restoration should be given instead. So you see that the tooth are almost edge to edge, right? And that's why, especially in the lateral incisor, if there's supposed to be a crown prep, and because the patient has parafunctional habit, you can see like adhesion all over. In such cases, ultrasonic should not be indicated and PFM should be indicated. Okay, coming to a summary of chart which you all can read. Yeah, so ulceramic crown preparations indication, contraindication, advantage and disadvantage are mentioned here. We have already discussed it. You can go through the summary. Okay, coming to the preparation, so armamentarium is given below here. It basically has a football shaped burr, a finishing stone, a carbide burr, mirror, periodontal probe. You have a flame shaped burr, you have a tapered fissure, you have a straight fissure. So you have all of these burrs with color gradients that denotes the grits or the coarseness of the burrs, right? Okay. So together with this, you need your high-speed handpiece. You also need a mouth mirror, periodontal probe, an explorer. You might need an explorer. You need cotton rolls. So the basic instruments are supposed to be used. Okay, coming to the step-by-step procedure, the preparation sequence for a ceramic crown is similar to that of metal ceramic crown. The principal difference is the need for a 1 mm wide chamfer circumferentially, right? So the chamfer preparation usually is done in the middle, and here we use a shoulder preparation, right? So you can see the labial and the lingual preparations in general, okay? Okay, and this is just the occlusal view of the same. All right. So coming to the incisal occlusal reduction, the completed reduction of the incisal edge should provide 1.5 to 2 mm of the clearance for the porcelain for all the excursive movements of the mandible, right? This enables fabrication of a cosmetically pleasing restoration with adequate strength, right? And the clearance will be proper. There will be no chipping, no fractures. All right. So you place the depth grooves just on the incisals 1 to 3 like we used to do. You take care of the incisal prep like 1.5 to 2 mm. Then you have 1.3 a depth of the incisal grooves in 2 planes, and that's how you prep. And then you do the reduction, right? Facial preparation, placing the depth grooves in 2 planes, and then 1 mm should be prepped. So you have 1 and you have 2 planes, right? That's how you prep. Incisal preparation is already done. Accomplish the thick reduction with the rounded tip tapered diamond, right? Yes, you can also do a chamfer margin. This is in not all the cases. Usually you'll be using a shoulder margin. Okay. Coming to the lingual reduction, you can use a football shaped diamond burr for the lingual reduction. You can place grooves also 0.8 mm, right? You can have 1 mm clearance all over. So again, I keep telling you to do reduction in 2 planes, the lingual fossa and the cingulum, right? So you can go around the cingulum, or you can slice it in a manner where you do not cut the cingulum too much, right? And that's how you do it. Okay. Finishing, you can see this is an intraoral picture, and you can see the amount of finishing which is done. And now we'll be taking impression for a ulceramic crown on 2-1 and 1-1. So finishing is done, and you should have rounded line angles so that there is no fracture. You can use a yellow band burr for this. All right, so usually you can see tapered diamond will do the job for all the preparation. You need a football shape, you might need a square tip diamond, you might need a fine grit, right? So 1.3 mm depth grooves, 1.5 mm clearance, 0.8 mm facial depth grooves, 1.2 mm a reduction in the two planes, right? So basically just a summary of the whole. Mechanical, biologic, and aesthetic, just like our crown preparation. So you have fracture of abutment, which can happen sometimes when you have not chosen the material properly, or you have not prepped the tooth properly, right? So, and the second can be chipping. So you can see chipping will be only in the crown. Fracture of the core, maybe if you have done a core buildup, it can be at the core. It can involve the core, right? So this is the preparation, this is the core, this is the crown. Debonding is something which can also result in if the patient eats too much sticky food or any type of food material. Sometimes, rarely, but debonding can happen if you have not followed the proper cementation principles. Okay, coming to the biologic failure. Post-operative sensitivity may be there because this you're reducing a little too much, more than the required if compared to the PFM crown, right? So it's a little bit more than the conventional clearance. So you're making the tooth a little smaller, so it may or may not result. Marginal micro leakage can happen. You can see this is the electron microscopic image, cement crown and micro leakage going on, right? So that can happen, and then you'll probably have to see the discoloration, and you'll have to probably cut and remove the crown and replace, and check for the vitality of the tooth if it's not treated. All right, coming to aesthetic failures, sometimes you might lead to poor shade selection. You can see that 1-1 is an all ceramic crown, and these are all natural teeth. There is a very, very, very important difference between a 2-1 and 1-1 crown. 1-1 and 2-1 tooth surface, right? So 1-1 is a crown, right? So in the second image here, you can see that there are visible margins, and again poor shade selection. So you're not able to camouflage the tooth structure properly, right? Coming to an improved image, which is the right image, there you can see a perfect camouflage, perfect margin, perfect shade selection. All right. So another type of error is in the tooth preparation, right? So this error remains in the tooth preparation. So those were the errors of the ceramic. This is of the tooth preparation. So now you can see in the image on the right, you can see all the flaws. You can see a sharp round angle, you can see roughened margins, right? The preparation is parallel on one surface, it's tapered on the other. So that means the axial wall is not reduced properly. It may be over reduced, but here it's adequate, here is under prepped, right? And it's not following a proper anatomy on one surface. So basically you need to follow the anatomy properly to get all these incorporated, right? Here you can see in the occlusal surface, this shows an inadequate reduction, this shows an adequate reduction because it has clearance all over even. Okay. Coming to principles of tooth preparation for all ceramic crowns, it will remain exactly the same, divided into biological, mechanical, aesthetic. We have to conserve the tooth structure, we have to avoid over contouring, we have to give supragingival margin, or I would argue here in the anterior we might provide either equi or subgingival margins, right? And of course we need to bring harmonious occlusion. We have to prep the tooth adequately so it prevents the fracture of the abutment later. And then you have to incorporate the retention resistance form, the proper margin, the proper symmetry, right? The proper taper, right? Everything has to be incorporated. The aesthetic has to be perfect because this is an all ceramic. Minimal display of metal. Here there will be no display of metal, right? Porcelain occlusal surfaces should be there. Subgingival margin would provide a better aesthetic, right? So when you meet all these three, there is an optimal restoration. Coming to patient demands. So all ceramic basically is evaluated by the doctor, but patient will get an all ceramic restoration because of the aesthetic requirement, occlusion, and function, right? So basically, if he or she wants a perfect aesthetic, has a perfect aesthetic requirement, he or she has to get an aesthetic all ceramic crown. Occlusion and function then will follow. Occlusion has to be perfectly done. If you have any high points, it will result into wearing off another tooth structure, and it may create fracture on the porcelain lid. Okay. Again, coming to the aesthetic requirements, I will go through the photos in the next slides, right? Okay. Coming to the amount and quality of the substructure, which is the third one. So adhesive cements have been improved long since they were introduced, and now they have a better stability. So research shows that abutment tooth vitality are at least at the rates between 2% to 4% after 5 years and 10% after 10 years of restoration. So that is still good. If it's a vital teeth, it still has 90% vitality, which is fine because it gets a little sensitive because of the tooth preparation. Okay, coming to the amount and quality of soft tissues. So basically, 80% of the population have thin, delicate, and rather translucent soft tissues, which can be found. 20% has thick and resilient soft tissue. So the differences maybe play in the restorative material selection. Again, also in the emergence profile of the crown, right? Which is the margin placement, which is also that if the tooth has a lot of strength, it can probably bear the all ceramic load because there's more preparation which is required. Okay, coming to the occlusal and functional requirements. So we have aesthetic zone and we have the functional zone. Aesthetic zone is on the interior. Functional zone is what you function with. That's the masticatory loads. So there the masticatory loads will be higher. We have different types of ceramics which can be used in the posterior teeth. So there are little differences in the material which are used in the anterior and which are used in the posterior teeth. All right. Okay. Coming to the aesthetic requirements, you can see there is one type of abutment. This is a little discolored abutment, right? And here this is a more translucent abutment. This has a metallic restoration as a core. So you can have 4 different type of aesthetic, and you can mask these with all ceramic restorations. Okay, coming to the translucency, so you can see there are so many blocks, right? So translucency of different ceramic materials. This is the lucite reinforced glass ceramic, feldspathic, zirconia, in-serum alumina, and in-serum zirconia, right? So you can see there's so many variations of the translucency, yeah? And that will give you more natural teeth-like appearance, right? Which is also under aesthetic requirements, guys, okay? Okay, guys, so lastly, just wanted to share a few of cases and just wanted to show you pre and post-op. So you can see a 4-unit bridge which was done, maybe a joint crown, and how the preparation done, and this is the abutments. Coming to the case, the second one which is on the lower side, you can see an adhesion. They all were root canal treated. This is under the light, the translucency, and you can see how this is a zirconia crown, and you can see how these 4, just to prevent the adhesion of the patient, it was root canal treated and they were crown placed. All right, coming to the third case here, You can see that the molars have severe attritions, yeah, and to mask this, of course, a root canal was done, and probably there was too much attrition and the dentine is exposed, and you can see how beautifully this restorations were done. Coming to an anterior bridge, so this is basically a 6-unit bridge, right? So it has 2 teeth missing, and usually you will take into account, you cannot have lateral as abutments. You'll take into account lateral canine and lateral canine, which is a 6-unit bridge, right? Alright guys, this is the bibliography. So Rosenstiel and Schellenberg remains the standard textbooks for us, right? There's the 6th edition, Rosenstiel, and Schellenberg is 4th edition. We do have it available in our library. Please refer to it. For any further questions, I'm always in Polyclinic 3. You can come and see me anytime. Thank you so much for patient listening.